Thank you to everyone who has joined us today for another one of our TB Care 2 webinars under the USAID project. Today's webinar is on FAST, Patient-Centered Administrative Infection Control. Dr. Dylan Tierney, a clinician scientist and infectious disease specialist at the Division of Global Health at Birmingham and Women's Hospital, will be leading the presentation, and I'll be handing it over to him to start.
Hello, everyone, and thank you for joining the call to talk about infection control, TB infection control. I'm excited to have this opportunity to talk about FAST. It's an administrative TB infection control strategy that I think is unique among all of the other infection control approaches that we have, because it really bears directly on patient care, and it's really centered around providing a rapid diagnosis and TB treatment as a way of preventing infection. So it has two real roles, right? One is that it's directly helping patients, but it's also preventing infection. So I think that's really important at this point in the epidemic and really thinking about quality of care. So basically, I'm going to review the general approach to infection control and how administrative controls fit into the overall framework of TB infection control. And then I will discuss how FAST is a specific administrative infection control intervention, and then I'll discuss FAST in some detail. I'll also present some data on the effectiveness of FAST as an infection control strategy. And then at the end, I'll spend a little bit of time talking about what's next for FAST implementation, and some questions that are still out there that I think really we need to answer about FAST for it to really be widely accepted. All right, so just some things to note. I have received research funding from the NIH to conduct research on FAST, and in one of our projects we have had a donation of QuantiFERON testing materials from QIAGEN. So we know that hospitals are hotspots for TB transmission. The most famous case is the highly publicized XDR TB outbreak at the Church of Scotland Hospital in Tagelferi, South Africa. And this is a photo of one of the wards from Tagelferi. So you can sort of see the arrangement for care there. Between January 2005 and March 2006, there were all of the patients who had positive TB sputum culture at the hospital, 41%, so 221 patients had MDR-TB, and 10% had TB that was resistant to all drugs tested, so isoniazid, rifampin, ethambutol, one of the injectables, streptomycin, and then Cipro and kanamycin. So basically XDR-TB. And the mortality rate for those patients was very high, like 98%. So, and really for all of the patients who were tested, they were all HIV positive. But what was interesting was that most of the patients with XDR-TB had never been treated for TB. So there was a really high level of genetic clustering that was observed among the isolates of those patients. So this was felt to be evidence that the XDR strains were associated with recent transmission. And there was a very high percentage of patients who were hospitalized within the past year, suggesting that there was nosocomial transmission. And then there was actually XDR-TB related deaths noted among several of the healthcare workers at the hospital, which also supported this idea that XDR-TB was being transmitted within the hospital, is really the kind of the focus of the outbreak. And I said it's the most famous, but it's certainly not the only hospital outbreak of MDR-TB or XDR-TB or TB in general. I'm sure that there are examples in your mind of maybe even in your own facility where there have been outbreaks of TB. So, and it sort of stands to reason, right? TB patients are seeking care at facilities. There's also susceptible patients who are at the hospitals either through immunocompromise or some other comorbidity. And there are very weak infection controls. And so this environment really is perfect for airborne transmission of tuberculosis. Further supporting the idea that these health facilities are places where TB transmission is occurring is data on TB infection and disease in health workers. So we know that health workers are at high risk for TB infection and disease. Study after study has demonstrated this finding. The risk of TB disease appears to be at least 3 times higher than the general population. So that suggests that these workers, health workers, are acquiring TB at their workplace, which is in a health facility. So TB infection prevention and control, which I'll may refer to in this talk as IPC. TB IPC has been designed to decrease the transmission of TB in congregate settings. They're recommended. IPC is basically recommended practice for hospitals and other healthcare facilities around the world. And there are really 3 main TB infection control activities: administrative controls, environmental controls, and personal protective equipment, or PPE. Administrative controls are felt to be the most important in terms of the hierarchy of TB infection controls. They are management measures that are intended to reduce the risk of exposure to persons with infectious TB. So they're broadly applied in health facilities. They're relatively inexpensive, and they're high impact. Environmental TB controls, so the goal of the environmental control is to try and prevent the spread of TB by reducing the concentration of airborne droplet nuclei in the environment, and decreasing the risk that someone will be exposed to those infectious particles through basically contaminated air removal or cleaning using ventilation or germicidal ultraviolet light. So it's basically kind of an air cleaning approach. And then finally, PPE, there are materials that are meant to protect health workers from these infectious aerosols. So the example in the picture is a personal air purifying respirator, a PAPR, but you're probably more familiar with the N95 respirator, which is used to decrease these inhalation of these infectious aerosols. So, in high burden countries, most of the TB care is really focused around case detection and treatment using DOTS strategy. So I think because the focus is on those interventions, even these kind of lower cost strategies to reduce TB transmission have not been well implemented. All right, so I'm going to talk a little bit more about administrative controls. So this is a list of administrative TB infection controls. They're all on the managerial side, and just want to highlight. So some of them are focused on, first of all, setting up structures within health facilities to control TB infection. So assigning someone the responsibility for TB infection control, conducting TB risk assessment in this at the setting, developing and implementing a written TB infection control plan, ensuring availability of recommended laboratory processing, testing, and reporting of results. So these are all managerial. The one that I want to highlight is this one: implementing effective work practices for managing patients who may have TB disease. So of all of these administrative infection controls that I have listed, this one is really focused on providing care for patients who have TB disease as a way of controlling TB infection, decreasing the infectiousness in those patients. So how do we decrease infectiousness of patients with TB? We know that TB is spread through an airborne route through droplet nuclei, infectious droplet nuclei. So a person with TB disease, usually with a large burden of TB bacilli in their lungs, which is irritating to the airway, those patients are coughing or generating infectious aerosols, and so when they cough, the aerosols are emitted and then are floating in the air for up to hours, and will infect anyone who is breathing in that contaminated air. We have a good model for this for infectiousness, which is the guinea pig. So when we expose guinea pigs to patients or to the air from patients with infectious forms of TB, we know that they become infected. So really the question is, what happens if we put patients with infectious forms of TB on effective treatment? Do we see a reduction in the infectiousness of those patients? And what do I mean by effective treatment? Effective treatment is treatment that is with medications that the strain that the person is infected with or has disease with are susceptible or that are active against. So the strain is, if it's drug susceptible TB, then we're treating with drugs that are targeted toward that. If it's MDR TB, we're treating with drugs that the strain will be susceptible to. So so here is this is an experiment to test the idea that effective treatment decreases transmission or interrupts transmission. So this is an experiment from the 1960s by Riley. And so in this experiment, guinea pigs were exposed to the air of patients with either treated or untreated forms of TB. And is a way of directly comparing the relative effects of treatment on the infectiousness of patients with drug susceptible and drug resistant TB. So for patients with susceptible TB, those who were untreated, so kind of in the first line, those guinea pigs, there were 29 guinea pigs infected, leading to a relative risk of 100%. So all of the guinea pigs were infected in those patients who were not treated. And then looking at the treated group of patients, only one guinea pig was infected. So it greatly decreased the risk of being infectious which is powerful evidence. There's basically a 98% reduction, and that was really just using 2 drugs. It was using INH and PAS and streptomycin. But so what's important to note, though, is that the patients who were, these patients were really, it was on the first day of they were only hospitalized on the first day before they received treatment. So this is not really smear conversion. Really, this is just kind of on the initial exposure. So we're testing really a rapid effect of the rapid effect of treatment on decreasing infectiousness. All right, so if we then have established that that hospitals are places where health workers acquire TB, and that TB is only transmitted from people with untreated disease, then we can ask the question, where in the hospital is TB transmission coming from? And, I think conventionally, we think about TB infection coming from patients with TB, and we have this image of patients in the pulmonary ward who are on treatment, and like this patient, with a known patient with TB, they're in rooms with lots of ventilation, they're wearing the surgical mask. But it's probably, these patients on treatment probably are not the patients who are at greatest risk for transmitting infection. It's probably patients who are undiagnosed or underdiagnosed that are more likely to be those transmitting TB. So I think about them in kind of in 3 groups. There are the patients who have active TB that are not yet on treatment. So, someone coming in with clear symptoms of TB, cough, fever, night sweats, when that person comes into the hospital, they're infectious. And so that is a potential source for transmission. There's also patients who have active TB disease who are unsuspected, right? They have less obvious symptoms, or they're coming into the hospital with an alternate diagnosis, either a diagnosis of, some other respiratory disease, bronchitis, COPD, lung cancer, when they also have TB, or they're there for another complaint entirely. A woman who is giving birth, or who is in labor, someone with chest pain. You can think about, there's a long list of reasons why patients go to the hospital, but those patients can also have TB. And so if they're unsuspected, that's a potential source for TB transmission. And then finally, I think about patients with drug-resistant forms of TB who are being treated with an ineffective regimen. So someone who has MDR-TB that's not known to have MDR-TB, they're thought to have drug-susceptible TB, but they're being treated with a drug-susceptible TB regimen that's not effective. So those patients, could also be transmitting drug-resistant forms of disease. So I think those really are the kind of 3 categories of patients we want to be thinking about when we are trying to identify possible targets for our infection control interventions and trying to get patients diagnosed and treated. But we also should think that the hospital is an environment with other people besides patients, right? There are also staff, and there are also visitors coming into health facilities that may have TB. And so, by focusing, I think, primarily on patients, that's probably the highest yield, but it may not fully reduce it may not fully clear the environment of infectious TB, because there are other sources that also need to be addressed, namely staff and visitors. Okay, so given all kind of this knowledge that hospitals are hotspots for TB transmission, and it's likely coming from patients with undiagnosed or underdiagnosed TB. About 10, 15 years ago, leaders in the TB infection control community developed a strategy to reduce TB transmission from unsuspected cases in health facilities. And this strategy is called FAST. It's an acronym using the first letters in English of the key steps in the strategy. So the F is for find cases, A is for actively, S is for separate safely, and treat effectively. So that tells you what the main sort of thrust of the activity is. So it's straightforward and it's pretty linear. Really, the first step is to identify cases of unsuspected TB through widespread TB screening of patients in health facilities. This screening is usually through a symptom-based approach. It can also include screening of additional TB risk factors. We can think about other screening tests that beyond symptom-based screening, like triage tests, like chest X-ray, but probably the easiest to implement right now is a symptom-based screen. So once someone is screened, then the second step is to test patients who have been identified through the screening as someone with a risk for TB. And we want to use a rapid diagnostic test that can, one, identify TB, but two, also provide drug susceptibility test results. Because once this diagnostic information is available, then the patient really needs to be started on TB treatment as the third step that is tailored to the drug susceptibility testing results as quickly as possible. So this pathway of patient care, right, of TB care is stepwise, and each of these three steps is critical. I don't mention the sort of the fourth step, which is the separate, as part of this kind of care cascade, but it is also important. And so, when we think about separating, we want to think about, really prioritizing the care of patients with TB, sort of getting them quickly started on treatment as a sort of way of separation, or if there's some isolation facilities available, then moving patients into those areas away from the general population. But I'm really going to be focusing on these three steps for the FAST intervention for this talk. So FAST is really designed to be a flexible intervention. Because it's, these three steps, some may say, oh, that's just, that's just good TB care. I think that's correct. It's really meant to be able to, we should be able to adapt it really to any clinical setting where patients are being cared for with TB. So, your hospital may have a screening, diagnosis, and treatment algorithm that's a little bit different from a hospital in another location. FAST is really intended to be able to fit in your facility and the other facility with just some minor tweaks to the overall flow of the care cascade. So I'm going to show you a sample flow chart. This is what this is how FAST is being implemented at a large general hospital in Lima, Peru, where we have a research study. So the three key steps that I mentioned in the last 2 slides ago, those are highlighted in that teal color. So first, hospitalized patients, this gray circle, they undergo a TB symptom screen. And should be noted that, hospitalized patients, some are the majority are passing through the emergency department, and some smaller percentage are, directly admitted to the ward. So it's important to kind of think about both populations when you're screening for TB. So for patients that screen positive, and what we ask in terms of our screening is whether the patients have a cough, any cough of any duration, whether they have a history of TB, So that includes patients who have a current diagnosis of TB or a previous diagnosis, and then whether they have any contact with people who have TB. And if the answer is yes to any of those questions, then they go on to some diagnostic testing. So in Peru, the guidelines say that patients should get a smear microscopy, and then a line probe assay. And so we, in parallel, are also doing expert, and then in parallel to that are getting culture and conventional drug susceptibility testing. So any positive results, our FAST team, basically the laboratory notifies our team of these positive results, and then our team notifies physicians and NTP nurses, National Tuberculosis Program nurses, so that they can initiate TB treatment. And ideally, the patient is then initiated on TB treatment that's informed by the drug susceptibility test. And then once our team kind of helps them, so they're there with them through the hospitalization, and then they refer the patient to their community health center to complete therapy or sort of transition care to outpatient at the end of their hospitalization. So, it's really, I think, the FAST intervention is really, number one, is a screening step, right? So it's sort of making sure that everybody is being screened for TB. And then it's really facilitating the flow of information to the clinicians, right? So facilitating the laboratory testing results to physicians and nurses, and then making sure that those that treatment is being started, effective treatment is being started, and then facilitating then the transition to an outpatient setting. So I just want to note that our approach to screening has sort of varied over the course of the project. We first started with a very simple screening of cough greater than 2 weeks. And that was kind of the Peruvian guidelines. But when we asked patients about cough for greater than 2 weeks, we had a very low number of people saying that they had a cough greater than 2 weeks, and we were sort of surprised by that low yield. And so we were wondering about, what was that question being interpreted incorrectly? Was it stigmatizing? So to broaden our yield, we then dropped the cough greater than 2 week criteria and just went to any cough. And then we expanded it to patients with a history of TB, because we recognize that, just because, you have a diagnosis of drug susceptible TB, that doesn't mean that if there was no drug susceptibility testing done, that doesn't mean that that's necessarily accurate. And so we wanted to include patients with a history of TB to verify that diagnosis was correct and make sure that they were on effective therapy. And I'll show you why we decided to include patients with a history of TB in another slide, and then also contacts. So just to say that I'm making that point because it's to underscore that this is meant to be a flexible intervention that can be changed based on your local experience. And if you notice that something is not working, it's meant to be adaptable and iterative. So the FAST team. I think the FAST team is really what powers this intervention. We established a team of 6 cough monitors. They're primarily based as I kind of mentioned, in the emergency department, because the majority of hospitalized patients, 85 to 90%, are entering the hospital through there. So they're focused on screening patients who are admitted to the hospital. They also go to the wards. And there's a supervisor who is who is kind of monitoring their work. They're reporting back on percentages of patients who are hospitalized at their screening. The supervisors collecting that information, and evaluating kind of the efficiency of their work. These are technicians. Their training is relatively, I would say, it's they're not as highly trained as a nurse. They are trained in how to screen for TB. They're trained in infection control protocols. They all are wearing N95 masks or respirators, when they're doing their when they're in the emergency department or in any area where they think that there may be patients with TB. They're working every day. They're there 7 a.m. to 4 p.m. On the off hours, when they're not working, the clinicians at the hospital have also been instructed on how to run, just to screen patients, and so in the morning at 7 a.m. our team comes in and there's a list of patients who were diagnosed overnight. Our team will then sort of assume them under the FAST protocol or the FAST intervention, and then facilitate the flow of information as I described on the FAST flow diagram. So one of the things that we really struggled with was trying to figure out, who are the patients that should be screened. We decided to focus on hospitalized patients because we felt like hospitalized patients are those patients who are going to be most likely to be contributing. If they have infectious forms of TB, right, they're there for hours to days to weeks. So we felt like those were the highest yield patients as potential sources of TB transmission. There are definitely other patients coming through the hospital that have shorter stays, whether that's through OPD or some sort of urgent care urgent care setup. Those patients are there really only for a short time, and so I think it's more difficult for the screening, diagnosis, and treatment to be initiated, in that period. So who are the hospitalized patients? Well, the hospital doesn't keep a really clear log of hospitalized patients from their central registry. So we had to come up with some other way of evaluating who is going to be hospitalized. I mean, it's on the wards, it's more clear because the patients are sitting in their bed and that, okay, that this patient is hospitalized. But in the emergency department, it's a little more fluid. So in this hospital, the nurses keep logs of patients that have been in the hospital for more than 3 hours and are likely to be hospitalized, and so that we use those lists to generate, a roster of patients who need to be screened for TB, and then so from those lists, our team goes out and finds those patients and asks them about the screening questions. This is something that if a hospital is going to implement FAST or a team is going to implement FAST, you really kind of need to make a decision about, who is going to qualify for the screening, and then how you're going to go from there. This model is a team-based model, right? A dedicated team. We could also imagine that FAST is being done by existing clinicians, nurses, triage clinicians, physicians, nursing technicians, but you're adding an additional task to an already overburdened workforce. So I think it becomes challenging, to add this task. So, I'm not saying it can't be done, but we chose the team model, a dedicated team model, because we wanted to make sure that this was done in a high quality way, that we could monitor, and that there was someone who had this responsibility that we could then, ask to do more if was necessary. All right, so I'm just now some evidence that about the FAST intervention. So this is some evidence that FAST is able to identify patients with TB. This is a pilot project of FAST implementation from a chest hospital in Bangladesh. So these are patients who have some respiratory complaint. This is in the capital city, Dhaka. There are three main categories of patients who are being seen at the hospital. Those with TB, coming in with either a diagnosis of TB or with clear symptoms of TB. Those with a chest disease other than TB, and then those who have a chest disease other than TB who also have a history of TB. So widespread FAST screening of all hospitalized patients was performed for about 1 year. And during this period, FAST detected drug-resistant TB in 4.6% of patients who were hospitalized with what was felt to be TB disease. But 8.8, so in patients who had some other lung disease, no suspicion for tuberculosis, FAST detected TB in 8.8% of those patients. And then in patients who are coming in with with some other lung disease, but also a history of TB, those patients, 21% of them actually had TB as their in addition to whatever sort of non-pulmonary TB disease was initially kind of thought to be driving their presentation. So I think this is pretty clear evidence that there are patients with TB being admitted to chest hospitals that, at least in Bangladesh, that would have gone undetected without screening. And I think it's pretty easy to, extrapolate these data to the facilities that we all work in TB endemic countries, to say, there are patients who are likely being hospitalized with transmissible forms of TB who are not being caught if you're not screening. So it sort of argues that the widespread screening is likely to have high yield in terms of detecting patients who have transmissible forms of TB. Excuse me. But screening is really only the first step in the FAST pathway. Diagnosis and treatment are really at the core of decreasing infectiousness. So we also want to sort of know what FAST does in terms of these two steps. So I think that there's really two key intervals, right? There's the time to diagnosis and the time to treatment. That's to say, the time from hospitalization, the moment that they walk into the hospital, to the time that they're diagnosed, and then and then to treatment. So by measuring these two things, we're really focusing on the two critical moments in the care cascade for patients with TB. It's a relatively straightforward calculation. These are data that are generally available. We know, hospitals record the day that someone is being hospitalized. The laboratory is collecting data on the day of diagnosis, either that's a positive smear, positive expert, or whatever the diagnostic test is that you're using, and then we know when treatment is initiated, either from the chart or from some NTP, National Tuberculosis Program log. But I think most importantly that these measures are really centered on decreasing the time of infectiousness. So they're important for us to track. I'm going to, I've talked about this in the past. If for the people who are implementing FAST that are listening, I think you really have to decide what your definitions are when you're tracking these things. What is hospitalization? Is that the time that the patient makes it onto the wards? Is that from the moment that they're triaged? And it really, I think, depends on local protocols and data sources. And as I said, FAST is meant to be flexible. So, you can make decisions that make the most sense for your facility when you're implementing FAST. And then, thinking about TB diagnosis, that's probably the date that the first test with TB is positive, whether that's a smear or expert or culture. It's likely going to be smear or expert if those are available. But you probably should also be tracking the date that the drug susceptibility testing is available. So, this all requires a really strong laboratory data management. But I think with strong laboratory data management, this is a very powerful sort of indicator, because you can tell, okay, this patient sat in our hospital for 2 days, 5 days, 10 days before they were diagnosed. Hopefully, it's less than 48 hours. But with strong laboratory data, you will be able to tell how long these patients are sitting undiagnosed. And then really the key measure is time from hospitalization to TB treatment, because as we know, treatment is what makes a patient non-infectious, or effective treatment is what makes a patient non-infectious. So, what are you measuring in terms of initiation of TB treatment? Well, it could be any TB treatment, but what we really care about is TB treatment that's going to make someone non-infectious, effective TB treatment. So we could talk about it as indicated, right? So if you know that a patient has a DRTB in their risk profile, right, they were a contact of someone with MDR-TB, and then you might say, well, that person really should have been treated with MDR-TB. So you kind of need to actually look at the drugs to say when someone was actually initiated on effective treatment. So that's a little bit more involved in terms of tracking data, because you do have to sort of make an assessment as to whether or not that treatment was effective or not effective. But the goal is really to have these patients being treated while they're hospitalized, or at least within a short amount of time while they're hospitalized. And so you need to be tracking this to kind of understand that information. So this is a FAST has been implemented in a couple of sites where we've been tracking the results. This is from a chest hospital in Vietnam. So I just wanted to point out a couple of things. There were, in this particular hospital, there were, in 1 year's time, there were 858 patients who were initiated on TB treatment. Only 57.5% of them were initiated on likely effective treatment that was informed by a drug susceptibility test. So how you decide whether or not, what you're going to track, whether that's any treatment or likely effective treatment, is going to, it's going to change your sort of understanding of, who is infectious or not infectious. I think we can probably presume that the large majority of patients who are started on any treatment is effective treatment, because most patients who are being treated with any treatment have DSTB, right, drug susceptible TB. But there are cases where patients have MDR-TB, but they're being started on drug susceptible TB treatment, and there were examples in this particular study of that. So. Other thing I wanted to point out here was, patients come into the hospital in a variety of different ways, and they're exposed to a variety of different testing pathways, right? So whether the sputum was collected as an inpatient initially, or whether their sputum was initially collected as an outpatient and they were referred to the hospital, right? So when are you going to start counting their day of diagnosis? Did someone get hospitalized first, then get an expert, or did they get hospitalized, then get a smear, then get an expert? In this particular facility, patients, the rule was patients who didn't have any risk factors for MDR-TB should only get a smear, and if that smear was negative, they should go on to get an expert. And so, here is some data showing that that matters in terms of their time to likely effective treatment. So for patients that were hospitalized and had some risk factors for MDR-TB, those patients got an immediate expert. And we see that in those patients, this is the kind of the left group of numbers. The time to effective treatment, 79% of them were treated within less than 2 days. As opposed to patients who didn't have any risk factors for MDR-TB, who got a smear first, and that smear was negative, and then got an expert, and then got treatment, right? So this is not a one-step, this is now a two-step diagnostic algorithm. We see that only 5.7% of those patients were treated within 2 days. So, we can debate whether or not these patients on the right are more or less less infectious than the ones on the left. But we know that they're all expert positive. So, still, I would be worried that these patients are also transmitting. And it just shows you that, but if you can expedite testing with expert for all, you're going to get patients started on treatment a lot faster. Okay. Just wanted to, that was a historical cohort, or at least a retrospective cohort. I just wanted to show you some data from Peru. This was a prospective cohort compared with a historical control. So from a pool of hospitalized patients, basically for this analysis, we focused on patients who had an existing diagnosis of TB. We excluded any patients who were coming to the hospital we excluded any patients who had an existing diagnosis of TB, and we're including patients who had a new diagnosis of TB. So there were 68 patients who were found to be smear positive with pulmonary TB diagnosed at the moment that they were hospitalized, and in a historical cohort, and then 48 patients with a new diagnosis of smear or expert positive TB in the prospective cohort. And then we collected data on 4 time points: the date of admission, the date of smear or expert, the date of drug susceptibility test results, and the date of initiation of TB treatment. And our analysis showed that FAST was associated with prompt drug susceptibility testing compared to the historical controls, where no FAST was present. There was so the time to drug susceptibility testing in the cohort that was the historical cohort that was pre-FAST was 38.6 days. Most of that was because of the sort of incubation times because of conventional DST. And then the median time to diagnosis in the FAST cohort, where expert was present, was 3.6 days. So that was highly significantly different. And we also found that the DST results were much more likely to be available at the time that TB treatment was initiated during hospitalization in the FAST cohort, which is critical for making an informed choice about effective treatment. Our analysis also showed that patients who were diagnosed with FAST in the prospective cohort were more likely to initiate TB treatment while they were hospitalized compared to the historical controls. And so this is obviously important because it's really this initiation of treatment that we believe decreases infectiousness. And so the length of hospitalization in both of these cohorts was about the same, right around the average. The length of hospitalization was around 5 days. So, we're seeing that patients under FAST are starting their treatment, while they're hospitalized. That their FAST is having an impact there. So, let's see. Oops. So I think we can conclude really that FAST improves key aspects of the TB care cascade. FAST is improving screening. It's FAST patients who are treated under FAST are more likely to have their diagnosis accompanied by a drug susceptibility test. that's available at the time of treatment. They're more likely to initiate treatment while they're hospitalized. So I think, all of these things suggest that, that the quality of care for patients with TB is improving under the FAST strategy. And that's why I like to think about it as a patient-centered administrative infection control intervention. But I think, the question is really, okay, so that's great. It's improving patient care. Is it having an impact in reducing TB transmission in health facilities? So that is the kind of the key question that still, I think, needs to be answered. We do have some research that shows that that is the case, that FAST is having an impact. This is a study from a hospital in Russia where FAST was being implemented. So in the period before FAST, 12% of patients acquired MDR-TB following their hospitalization. So they came in with drug-susceptible TB, and then they at some point later were diagnosed with MDR-TB, and these are hospitalized patients, right? So once then FAST was implemented, and they looked at the same thing, and patients were hospitalized with DSTB, sort of on the right, but FAST was kind of running at the hospital, and then they saw that the rate of acquired MDR-TB, or at least MDR-TB, after hospitalization, went down to 3%. So FAST was associated with a 9.2% reduction in the risk of acquiring MDR-TB. So as we know, as a kind of the first example I gave you of Tagella-Ferry, right? We know that drug-resistant TB is being transmitted in these facilities. I think this research study shows that FAST has an impact in decreasing that amount of transmitted drug-resistant TB. And then the second study, which is ongoing, and later today I'm going to have a call to see whether these results are, to get some update on these results. But really, this is from Peru, where we're going to be measuring the incidence of TB infection in health workers, right? So the health workers, physician interns and nursing interns, when they come into the hospital, there's about 10% of them that are infected with TB at baseline. So what we're studying is whether or not there is an increase in the level of TB infections over time. So we're testing them with QuantiFERON at the start of their internship, and then again at the end of their internship, and we want to see whether in intervention hospital where FAST is present, whether the incidence of TB infection is lower compared to control hospitals where FAST is not running. So I think if this, if we get results here that are positive, I think it's going to be a very important finding, suggesting that FAST does have an impact in decreasing infection in hospitals. So I think that there's evidence to support FAST implementation, but we may ask, okay, well, what do is it hard to implement? And we're also studying this. We're doing a little bit of qualitative research, asking people who are implementing FAST what they think of the approach, because really it's the people who are doing the work that I think are going to be key in making in arguing for its implementation, because it is trying to create healthy and safe workspaces. So these are a couple of quotes. You can read them. I'm not going to read them for you, but just to say that health providers recognize that FAST is a patient-centered approach that's improving quality of care for patients with TB, and they also recognize that it is an infection control intervention that's decreasing the source of infectious TB, namely patients with with unsuspected or untreated TB, and kind of across the board, our workers are very positive about FAST as a strategy to create a healthy and safe working environment. So some unanswered questions. I think because I'm saying it's a patient-centered approach, we're showing that FAST is in the care cascade is improving the quality of care. I think it would be really, really, really important to ask patients what they think about FAST. do patients like being screened in the hospital for TB? Do they feel stigmatized? There's lots of questions there that need to be answered. We don't really understand what the impact of FAST is on treatment completion and cure. We imagine that it has, if anything, it improves cure because we're starting treatment faster. But there may be some questions about whether that transition of being started on treatment in the hospital and then having to transition as an outpatient, does that have some, is there any negative impact there? Can FAST be implemented in settings that prioritize the initiation of treatment as an outpatient, right? So is FAST valuable in a clinical setting, an outpatient clinical setting? I think that remains to be answered. Is FAST cost effective, right? We're spending money screening patients who, many of them don't have TB. What is the cost associated with that? What is the benefit? We're studying that, and we'll have some information about that hopefully early next year. And then is it sustainable? Do health facilities see value in FAST? And is it something that they want to? Do they have the political will to fund FAST over time? So I think these are all questions that need to be answered. But I think overall, we're very excited about FAST as an administrative infection control, and we think it has benefit. So I know the time is sort of short. I'm happy to answer one or two questions, or I can take them offline.
Thanks, Dylan. This is Niraj from URC. Excellent presentation. I just want to add a few things. We've been using under a program FAST in South Africa, and during the last year, I believe FAST identified more than 6,000 or 7,000 missing cases because a large number of hospitals were implementing FAST program. And I think we'll discuss this with Matsi and all that. Maybe this is something, looking at the data to look at the cost effectiveness of this program in South Africa. So.
Right. So we're doing, in our cost effectiveness analysis, we're trying to build a model that, so there's a few immediate benefits, right? There's the benefit in terms of the patient, right? So you're potentially reducing the time to diagnosis and treatment, and so maybe there's some improved cure. Then there's the benefit of transmission in the health facility, right? So you're cutting down number of TB infections, but we also have to model in what the transmission that's happening outside of the hospital, right? So patients who are out there transmitting TB, I think, as a kind of a secondary or knock-on effect that also has to be built into the cost effectiveness model, and we're going to try and do that. So yeah, I completely agree with you.
Any other questions? I think there's a hand raised. Yes, Shahid?
I don't see any questions on my screen, so someone.
No, there's somebody's raised their hand. Oh, maybe it's yeah.
I'm Shahid Khokar from Pakistan. This was a very informative presentation given by the presenter. My question regarding the multi-drug resistance is whether the FAST has reduced the loss to follow-up in the MDR cases, and how many cases have gone in the treatment failure?
So are you asking whether, so when someone's diagnosed with MDR-TB in the hospital, whether they are lost to follow-up when they're then sent to continue treatment as an outpatient? Is that what? Yeah, so that's a really important question that we also want to answer. Unfortunately, our current studies are not designed to answer that question, but I think in future studies we do want to answer that, because I think, right, I do have some concerns that, by starting someone potentially, if you're in a system where it's set up to deliver MDR-TB care primarily as an outpatient, right? And we're trying to reduce the time that these patients are being hospitalized from, 6 months in an old way to, only a few weeks in the kind of the more current imaginations of the care, right? Like, is 2 weeks long enough for someone to really feel good about their MDR-TB treatment and could they be lost to follow-up? I think that that's a really important question. We need to study that.
Thank you.
All right. If no questions, I want to say.
Niraj?
Yes, sir. Yes.
Yeah, just a comment. Thanks, Dylan, for that overview. Two things just to mention quickly, and I think one is that what are the limitations of FAST? I think Dylan alluded to some of those. For example, on the outpatient basis, there really isn't much time to impact transmission because even if you identify a cougher, et cetera, you can do some isolation, but rapidly getting people on treatment in the outpatient basis is probably not a practical goal. But certainly there have been cough monitors, for example, tried in Peru, et cetera. We envision this primarily as an inpatient to avoid prolonged exposure to undetected TB cases or undetected drug-resistant cases. And right now, that's our goal. One could also ask, should this be applied to the community? And there's lots of studies of active case finding in the community. Again, the goals are just slightly different. Finding that large number of undetected cases is important. It doesn't emphasize speed so much. One of the things that the FAST acronym captures is the need to do this all very quickly, especially in the hospital, so that instead of 7 days exposure or 8 days exposure, you reduce the time to diagnosis and effective treatment to a matter of a day or less, or sometimes 2 days. That's what they've done in Russia. Very quick implementation of treatment after diagnosis of a drug-resistant TB, for example. So there are limitations. This is not a fix for everything, and it doesn't really deal with follow-up. And that is a separate issue, what happens to the patients that are diagnosed. But we're trying to, this began as a request from USAID in the 2009 union meeting in Berlin to come up with the most effective intervention there is for infection control if you had to do just one thing. And we don't have to do just one thing. We can do the environmental and we can do respirators as well. But the administrative controls are terribly important, as Dylan has pointed out. And what I think we've done with FAST is to better define what administrative control means. It's really identifying patients and getting them on therapy quickly. That's all I wanted to say.
Okay, thank you very much. We'll have more sessions on infection control. I think we have another one next week on UVGI, so we'll be sending out notes about that. So thank you very much. And thanks, Sharanya, for organizing it.
Yeah, thank you, Dylan, for leading a great presentation. To any attendees still on, we will be sending out the webinar recording and the presentation as well. And it's also available on tb.academy. Thank you so much for everyone who's able to make the time to join us today.
Thank you.